for us. For the next half portion of this morning, we're going to be having a series of panel discussions and continue on with our speakers with the various presentations as well. So before we get started onto that, I did want to just mention just a few more elements. If you are having any technical difficulties, please again email us at cteotechsupport@cms.hhs.gov. For all questions, we are currently going to actually have you all email all of your questions pertaining to each of the sessions. We do ask that you identify the speakers or the session name, and we'll go ahead and get the content and that question over to that group of presenters for immediate response. So without further ado, let's go ahead and continue on with our program this morning. Next up, we have identifying effective uses for information technology. Now, this is actually going to be an open panel discussion. We have a team of highly energetic, actually, presenters right behind me here, eager to get started and share with you some of the conversations and best practices they have in mind. To get us started here, we have from Cigna Healthcare, John Parnente. Hello, how are you, John? Good to see you.
Good morning.
Good morning. Thank you for joining us. John is the Chief Medical Information Officer, and we also have from Exelis Health Plan Incorporated, we have Gloria Barnes. Hi, Gloria. Welcome. Nice to see you there as well. Again, Gloria is, again, the Director of Medicare Care Management. And we also have from Exelis Health Plan, Susan Brown. Hello, Susan Brown. Can you just give us a quick wave to the audience in the virtual world? Welcome as well. And in addition to that, we also have several members from Genchester Health Plan. Dr. Frederick Bloom, welcome. How are you, sir? We look forward to having further discussions and conversations here shortly. Again, and then we also have Richard Betting, Vice President of Actual Informatics as well here to join us. Hello, Richard. So there you have it, everyone. This is our panel. Again, our topic of discussion is really around identifying effective uses for information technology. So I'm going to go ahead and ask the panel group a series of questions, and hopefully you can share with us some of those insightful elements you have learned along the way. So the first question that we have on our minds is that of a common practice among high-performing health plans is a movement towards automating processes and establishing electronic medical records, EMR. Can you give us an example of how your organization has automated processes and what efficiencies were created as a result? Again, panel, I open it to the floor.
So I'll start with that one. So a lot of our efficiencies were brought about through the use of the EMR, and the EMR allowed us to do processes to improve quality, to improve the safety of our patients, and also to improve efficiencies. So I'll give a couple examples of some of the things that we've done. The first is in implementing the EHR, we did basically get an automatic tickler system. So in the old process, when a provider would order a lab test or an imaging test or even a referral, that information would be put on a piece of paper and filed somewhere, or it was just a verbal communication with the patient. We need to see you back in 3 months, et cetera, or I want you to have a lab test before you come back and see me in 3 months. So now with the EHR, every time an order is placed in there, if that order is not completed or fulfilled, a task would come back to the support staff notifying them of that gap. So obviously this was a big improvement in the care that we gave. We did undergo some cultural shifts with that because in the old days there was a lot of work to look at a stack of labs that patients never came to get done, and a lot of times those paper orders went into the trash rather than being looked up and the patient contacted around that. One of the interesting processes that we did and really got a lot of provider buy-in from this, because Obviously, these processes were frustrating for providers when patients wouldn't come back for necessary tests, or we use the example of a patient who you saw a lesion on a skin exam and you write a referral to dermatology. Well, unless you kept a paper tickler to see if they actually went about a concerning lesion, it might be that next time you're seeing them at their physical a year later, you say, whatever happened, you know, when you saw the dermatologist about that lesion? And they would say, well, I never went, or I had some issue with getting the referral. So we've also used the ticklers around our referral process. What we've done to help with the efficiencies with this is not rely on the back office staff to be the first to address the issue. So we've configured the EHR to actually send the task to our medical records department when that referral becomes overdue. They then make the first contact to the specialist to find out, was it that the patient just never called? Did they no-show an appointment, or is the appointment in the future? Obviously, if they have never called, then they allow that task to go to the back office staff for them to work it from a clinical perspective and then notify the provider. If the patient hasn't yet been seen but they're scheduled, then they'll move the task out to the future, so that task will come back. And if it has been completed, the patient has had an appointment but we just don't have the records yet, then they'll ask for those records to come back to us, and once they do come in, and move the order out, but when that does come in, then they'll be able to complete the order appropriately. Another thing that we felt very important to improve efficiencies was really in how we set up the chart. We didn't want to mimic the paper record and, you know, say, well, all the labs go in this section and the imaging studies go in this section. So we did break it down. So if you had labs that pertain to specific diseases, we built flow sheets to show how they look sequentially, but also to make it easier, depending on your role, what you might be looking at the chart for. An example would be if I'm a gastroenterologist, obviously I'd want to look at a screen that shows all my GI notes as well as any imaging studies or labs that I've ordered. But we even took that same process down to people in our medical records department or people on our outreach teams, and basically providing, showing them in the chart those things that they would most often use. Doesn't mean they can't see the other things, but very quickly they can get a sense of what it is they need to see. We found this to really improve the ability to learn the EHR as well as their ability to do the job. And a lot of this information, you know, was made spending time with the teams that were doing the work and saying, well, you know, this chart's not really configured how you use it, so let's reconfigure that. So we spent some time on customizing that. And then the last thing would be the refill process. So having electronic refills come back in the EHR has really streamlined, and that's probably where we found the greatest efficiencies, because these are our licensed nurses, our RNs, and our LPNs who were basically handling the refills. They had a process in place that they would know, depending on the medication, what labs needed to be up to date or how often the visits needed to be. So they had a protocol that they would work through. But now with the automation, with everything coming in electronically, they have the patient's chart right there. We built them a specific view to basically say, yes, you can renew this medication, and they would do that. If they were unable to renew it, then obviously they send that task to the provider to take care of. So there are some of the examples of some of the processes that we've automated.
Great, thank you so much for that. Anyone else on the panel have any areas they would like to share with the audience?
Sure, I can go ahead. So just to frame our conversation a little bit, Excellus Blue Cross and Blue Shield is in upstate New York, and we have a broad range of urban and rural markets that we serve for our Medicare population. So our challenge has been how to increase collaboration, and it has been a historical framework that Excellus has worked on. Part of our mission is to serve the population, the community, so it goes beyond our membership. So one of the approaches that we have used is we have multiple EHRs available, so it's really try to collaborate with other health plans in the community to try to bring together meaningful data to our providers so that it can be actionable and it can speak on in their terms, as opposed to having multiple report cards, if you will, available to them, and then mitigating that way how we target our membership. So that has been an approach, and to that extent, basically we have had a pilot on medical homes that Sue can maybe dovetail a little bit more and provide more detail on.
Okay.
I'm happy to do that. In Rochester, New York, we had a medical home initiative, and it was actually a multi-payer initiative between Excellus Health Plan, and also included MVP, the other large area health plan. So really looking, as Gloriella said, at community collaboration across practices, looking at shared goals and really improving the health of the community. And the goal was to create efficiencies, looking at practice transformation and also care management. So really two sides. As Gloriella mentioned, we're a bit different in that we have direct contract providers, so each might be using a different EHR system. And so we used a data aggregator to be able to pull that information together for the pilot. And we actually had obtained a grant to evaluate the pilot, but that was only for the evaluation itself. Things that we did to help create efficiencies and really figure out what we needed to do was to hold meetings between the health plans, the hospitals, and our primary care practices that were part of the medical home initiative. We helped create meetings within the practices themselves that were multidisciplinary, and added 0.25 FTE to each physician to help work what needed to be done. So for example, let's say a member had a gap in care, helping do that outreach, for example, as Dr. Parenti mentioned earlier. We also did a lot of education as far as lean principles, care management, building the role of the care manager within the practices, defining new standards as we needed to, and then also working with the data as far as creating new reports, help creating and streamlining workflows and the like. Using this data helped us create a patient registry through the web portal that, for example, identified gaps in care that could later be worked.
Fantastic. Thank you so much, ladies, for that. Again, gentlemen, any additional examples anyone else would like to share from the panel?
Yes, Geisinger Health System, for those of you who don't know, is in central Pennsylvania and northeast Pennsylvania. It's primarily a rural service area. And across this 250 miles, we have about 2.6 million people. Now, Geisinger Health System has 5 hospitals. We have about 1,000 physicians, but we also have a health plan, and the health plan is a 400,000 member health plan, and about half of the patients in our health plan have a non-Geisinger primary care physician. About half of the patients have a Geisinger primary care physician. So all of the models that we work with address both the integrated health system as well as the community providers. So we have similar issues around data as some of the other speakers have discussed already today. But we do feel that it's very important that we use data to redesign care and drive innovation in our primary care sites especially. Geisinger has had Epic as our electronic medical record since 1996. But we do deal with a variety of electronic medical records and paper charts in non-Geisinger practices. And so developing workflows that work both within the integrated health system in Epic, our electronic medical record, as well as other electronic medical records and paper systems is important. And sometimes the health plan, especially on those sites that have smaller EHRs or paper charts, the health plan really can provide the best data to help them to redesign their care. Now, we use a medical home model similar to what's been described. Our medical home model is a little bit different than other medical home models in that it started back in 2006, a year before the principles, the joint principles for medical home were established. So at that time, many medical home models had different looks. And so our medical home model focuses on 5 things. It focuses on primary care redesign, on an integrated case manager, and we think it's very important that that case manager be integrated into the primary care site. It focuses on the medical neighborhood. It also focuses on the quality program and then the financial aspects and the redesign that are a part of that. But a big part of this is the redesign, the primary care redesign, and seeing the health plan as a partner in that redesign. You know, the electronic medical records that Geisinger has and other systems have are wonderful. They can give you accurate clinical information that sometimes is better than the claims-based data from the health plan. But it's not just about turning on an electronic medical record in your office. That doesn't solve your problems. For those of you, know who've done that, actually can make it more difficult sometimes. But what it is good for is it has a lot of tools. It has a lot of alerts and reminders and things that can help you to hardwire new workflows into place. What it's really about is that workflow redesign, and the health plan has been a partner to primary care practices to help to redesign their workflows, to look at how they can develop new systems of care in their practices using the data either from the health plan or the health plan to help them to develop information from their own practices that help them with this data-driven redesign. And it's really about a team-based model of care with delegated, accountable responsibilities for everyone in the practice to help to do that. Now, the primary care redesign is the first component, as I said. The second component of our medical home is our integrated case manager. And so we have a case manager who works in the primary care sites, both Geisinger primary care sites and non-Geisinger primary care sites, a case manager from the health plan who works at the site and helps to risk stratify the population and uses information that the health plan can provide, reports and data that Rich will talk more about later, that helps to stratify the population, identify who is the complex patient who needs case management, who then the case manager can work more closely with the practice in a very integrated way so that the patient sees the case manager as a part of the primary care team. The physician and the case manager develop a very close relationship, and so they both are sharing the same data resources, they both look at the same reports, they both are focused on the same care gaps that are necessary to close. The third component, as I said, is our medical neighborhood, and we also have data around our medical neighborhood. So using the information from the health plan to be able to provide primary care physicians with information on the value of different services. You know, for a long time we've known about quality of care. A primary care physician has a good judge of the quality of the services that a specialist or a home health agency or high-end imaging center might provide in the community. But until you have reports on cost, it's hard to make that value-based decision. You know, cost is the value is the relationship of quality and cost. And once you have some of the cost data, you can start to make a real value-based decision. I always say in Wilkes-Barre, Pennsylvania, a small town in northeast Pennsylvania, I had 4 MRI facilities that I could choose from. All of them had great quality MRIs until I had a health plan that was providing data to my practice. I didn't know that one of those MRI providers was almost 3 times as much as another MRI provider in town. And so if they're equal quality, why not use the highest value provider? And so having that kind of information about the medical neighborhood that we can provide to practices is important too. And so we provide information around imaging centers and home health agencies and skilled nursing facilities and specialists as well around value. The next component is around quality, and we do focus on quality in our medical home. Our medical home is called Proven Health Navigator. And because first and foremost, this redesign is about improving the quality of care. Yes, it does increase the reimbursement. There's a for performance associated with it, but really it's about improving the quality of care that we provide to patients. And so providing those quality of care reports, HEDIS reports, other care gap reports of needed care in a proactive way to practices. As I said, many of them, they don't have their own registries in their health plan registry that we can give them around diabetes or coronary artery disease or hypertension is sometimes the best information that they can provide. And then of course, having reports around the finances and the redesign of our reimbursement model is important too, and Rich will talk more about that later in the presentation.
Exactly. Thank you very much. Mr. Betting, any comments from you as well?
We're going to allow the EHR to be the focus on our first question, then I'm going to speak more to the second question.
Okay, thank you. All right, well, thank you very much, panelists, for that. There are several other questions that did come in, and we'd like to also bring those to your attention. A second question that has been raised is, as a result of updating IT systems, some plans have been able to generate real-time reports with useful information that is easy to decipher by people at different levels of the organization. What are some of the benefits you've experienced from automating processes or improving reporting? And can you give us a comparison of before and after? I'm going to go ahead and open this up to Cigna Healthcare representatives from there. Go ahead.
Okay. Thank you. So what I want to talk about, one of the things we used to do as a patient registry that was really based on gaps in care or quality metrics that we were looking at. So an example might be that patient who's overdue, let's say for hemoglobin A1C for diabetes, and we would print a list, and that list would be distributed out to the different centers, and the back office nurses were asked to work those when they had time to do that. So after we installed our EHR and we were looking at reporting, and again we're using data aggregated both from the EHR as well as from the health plan, because again when patients go outside of our system, there's often a lot of data there that's helpful. But we decided to make our patient registry more patient-centric. So what we did is it looked at each patient specifically and said, what are these patients' gaps? What are their values that might be overdue? And we did that across a variety of things. So not only immunizations, but also looking at health maintenance, such as colonoscopy, mammography, disease-specific things such as cholesterol, diabetes control, have they had a retinal eye exam, have they been in with their PCP in the past 6 months? Some of those basic type things. And then we stratified that list and saying who had the most gaps, and that patient would be at the top. Rather than distribute this to the centers, we decided to do this on a more pod-based structure and basically use, in a sense, a care manager, but this was actually an LPN whose role it was to engage the patient, engage them around the gaps, around the quality, and basically work through the process. We set up a series of standing orders to allow the LPN to order any test that might be have a gap, but also gave them the ability to schedule the retinal eye exam, help the patient schedule for the specialist if that was what was needed, schedule with the primary, schedule the mammogram, rather than just order the things and let it go through the normal process. Why they had the patient on the phone, they scheduled that. We also spent a lot of time with them, and probably since they weren't case managers by training, talking to them about how to break down some of the barriers that patients bring up when they're being called. Typically, these are the patients that are difficult, which is why they have so many gaps. Either they're not coming in or whatever the case might be. So we did allow them to connect with the social workers and other things, but there was just some very basic things that really helped improve getting the patients taken care of. Simple questions about transportation issues and giving them some means of alternate ways that the patient might be able to make it to the appointment. Maybe scheduling some things together, an appointment with the PCP at 9 o'clock, your mammogram at 10, You get your lab work when you first come in. So kind of once, come in one time and get all the, get everything taken care of. The other important piece of this, and probably the most important piece of this, was listening to the LPNs that were doing the work. And actually, we've been doing this for over a year and a half, and we still meet weekly. We meet 30 minutes every Friday afternoon, but for several reasons. One is they're the ones that were doing the work, and to be able to, and I alluded to earlier, configure the process to what works for them was very important. It really helped engage them, and it really helped engage the conversation amongst the 6 of them with the operations staff and with myself and the medical leadership around what was actually happening when they were making those calls. Another important thing was a feedback loop. And one thing that the old spreadsheets lacked is if they were put out every month, someone's going to read down the list and work the list, and the next month they get another list. We update this every couple days, and we allow them, we built them areas in the EHR where they can say that, they called and didn't get an answer, or those type things, which constantly updates or re-stratifies the list, so to speak. They even had a place in there where, if the patient didn't want to be called again, or being in the desert in Arizona this time of year, a lot of our patients are at better climates, so they might want to call back in September or October when they come back. So we made sure the system can handle that, and that patient would come off of that list and then reappear at the end of September or the beginning of October, so we can make those outreaches. So we found that to be a huge step in the right direction with that. Some other things that came up outside of just transportation barriers were just conversations around the doctor. We found that sometimes patients were a little hesitant to come in because maybe they didn't like their doctor, or maybe the last time they were in, it wasn't as good a visit as maybe they hoped for. And this was something that the LPNs brought to our attention, and that we worked on with coaching them about how to broach that, and maybe offer them an appointment with a colleague or even at a different center. So those were types of things that really helped us with that. Our rates have improved tremendously around the quality, just having these 6 people. And we're talking, we have between 38 and 40,000 Medicare Advantage lives, and with 6 nurses making those phone calls. Diabetes, retinal eye exams alone, we improved by 13%. And not only was it them doing the outreach calls, but it was also taking down that process of, you need to talk to a vision front office person to schedule the appointment. Allowing the registry team to do that, that just took down, one extra step that people had to do for the patients to be able to come in. So I think.
Okay, thank you very much for that. Do we have any comments from the Exelis Health Group?
Sure. One of our focus in terms of generating real-time reports and a challenge for any health plan is trying to move away from utilizing claims data, which has such a long lag, and it has a lot of missed opportunities. So one of the real-time approaches we used was trying to utilize discharge data from the hospitals in lieu of claims data. And we did a number of different things. We utilized the Plan, Do, Check, and Act process that was earlier commented on, and also tried to focus on root cause analysis to try to understand what discharges to try to approach with this insight. Obviously, there's a lot of patients' discharges, and some of them are most effective if we utilize care management. Others are surgical discharges that have staging procedures, and so you really are not going to be able to affect the fact that people need to be rehospitalized for those. So we did focus quite a bit on looking at our PQI data, the preventive quality indicator information, what were the key drivers of readmission to the hospital, and then utilized hospital information, discharge data to create a quality improvement plan, which many of you know is part of CMS's requirements regarding all causes of readmission. So our approach was to try to utilize this mechanism of enhancing real-time information to try to work on this project and program.
I'm going to go back to the medical home for a moment to answer part of this question. one of the things that we found with all of this focus, again, embedded care management, but I didn't mention earlier that we also had plan staff who were working directly with the practices on their process improvement initiatives. So they helped with for example, with that root cause analysis and what they were going to do different. And not only did they work on quality initiatives and quality-related measures, the national measures, again, diabetes, CAD, blood pressure, LDL, I mean, the ones that you're all very familiar with. But they also worked on, for example, patients being seen within 15 minutes of their scheduled appointment time. And I must admit, I go to one of these practices as part of the medical home, and there was a big sign up at one point a couple of years ago that said, if you're not seen within 15 minutes, let the front desk staff know. So that's something I'd never seen before, and I think we've all been to providers. Some of them are very good about that, but not all. So, also wanted to mention that, again, we had a formal evaluation. Our medical home pilot was over 3 years, started in 2009, ended in 2012, but we did definitely see some significant improvements. So, for example, a significant improvement in mammography, colorectal screen, some of the preventive health measures, ER use in these practices down almost 10%, and preventable hospitalizations down very significantly. But when I'm talking about the preventable hospitalizations, how they measured that was using, for example, pneumonia, some of the ones that are very specific, that well known to potentially be preventable if primary care is put in place in time.
Okay, and Richard Betting, we'll go ahead and see if you have comments as well.
Well, the one thing for sure is it's an exciting time to be in an informatics-related field in healthcare. We've never before have had so many choices, so many options, and so many challenges as we look at the velocity of the data and when it's available. So there's a lot of emphasis right now as we kind of discuss about the real-time components. And I kind of split the uses between operational and strategic analytics. And I think my peers here have spoken very clearly as to the importance of getting the right information at the right time so that the impact can be made. As was discussed, the medical claims data can certainly be beyond the point of intervention, and that would limit the type of use. So at Geisinger Health Plan, my department within actuarial informatics, as well as a sister department which is called clinical informatics, are the two main cogs that we use to support the flow of information and transparency to our Proven Health Navigator medical home sites. And we take a lot of different sources as we look at that. So we will look at the EHR, we will look at the medical claims, the pharmaceutical claims, we'll look at survey data. We also have access into the Health Information Exchange in our area. And as we continue to build things out, we're looking down the road about integration of socioeconomic factors and how can we continue to build on biometric data, et cetera, to make the transparency even more robust. We have an enterprise data warehouse that aggregates this information, brings it together, brings it to life so that we can support both of these functions. And we also have a variety of other applications in-house, which include predictive modeling, physician profiling, our quality reports, and we also are in the process and very close to implementation of our health services information system, which we think is going to be a great aggregator and accelerator of information that is going to be very naturally intuitive and accessible. So one of the biggest challenges that we've had with the introduction of our Proven Health Navigator model is back in 2006, once we kicked it off, there it is now, what are we going to measure? So what are those key performance indicators? What are those metrics of interest? There's a lot of opportunities to report and overload your clinical partner, and you really have to be specific and understand what elements you need to make that transparency with, and then have a partnership with the clinical partner so that you as analytic experts combined with the point of care and clinical folks can look and identify not only is there a trend, because back in the day, again, it was great to know where your trends were, where you were not benchmarking well, where you were moderately or loosely managed. Today, that's yesterday's news. Today, we need to get into subcategories, and we need to look, and if we have an opportunity within our utilization for emergency room visits, we have to look at that and say, are these discretionary visits or are these urgent visits? And if there are discretionary visits, is there a day of the week or hour of the day? So one of the powers that we have within Geisinger as an integrated delivery system of care, we have on the health plan side access into the EHR, so we pull a lot of lab result information or time of day, so 50% of the care roughly that is delivered to our membership actually comes from our clinical enterprise and our hospital facilities, and we have the opportunity to see a richer level of transparency of information as a health plan that we would not otherwise get to see. And I think, Dr. Bloom and others had mentioned the converse is true as well. So the health plan has information on care that was delivered outside of the Geisinger health system that gives us that full 360-degree view so that we can sit down and create an awareness with the clinical partners and be able to develop strategies that are going to lead to change and action and impact.
Wow. Thank you all very much. That's fantastic. I mean, the conversations between all three organizations here today is very impactful. We're learning a lot just from hearing what you all have experienced and sharing with us today. There is one more question, and it's actually our final question, that I would like to pose to the panel today as well. What are some of the challenges you have faced in implementing improved information technology solutions, and how have you overcome those barriers? I'm going to go ahead and let's start off with our ladies over in the corner there from Excelis Health Plan.
One of the things we needed to work on initially is to look at our data and clean it up where necessary. And I don't know if anybody else has had that experience, but when you look at it at a level of detail, you find from physicians, that's not my member. Things like that. And we had to go back, look at the data, and look at consistent reporting, and develop new reports where necessary. And in addition to that, teach the practices, in some cases, how to use the reports. And as we heard earlier, at the practices, you're looking at a multidisciplinary team. There's some people who have not used that type of report before. They're new reports that you create based on what the need is at the time. So we really need to look at, for example, consistent documentation processes and how to understand the reports, make them actionable, and with that action, what the practice is going to do in order to make improvements. Something else we were challenged on was lab data. For example, our labs don't consistently come in through the EHRs, even if the system has an EHR. And so, for example, they might come in via fax. We'd have to make sure that that data was entered. We might get some of the information through the PQRS piece, but that's not saying, for example, I've got a hemoglobin A1C of 9, and I've got to do something about that right now. Quite the same way, so that you really needed that level of detail and make sure that was available to the practices and the folks caring for members. Something else we were challenged with was making sure we got the right amount of information, and that's something we're currently working on. For example, hospital discharge information. Some cases we were finding we were routinely getting the information. Some cases we were finding out we were getting it multiple times, not just once. And in some cases, perhaps not at all. So we had some work, and we do have some work, on making sure we get the right information from the right sources on a regular basis.
Thank you, ladies, for that. Jensinger, Health Plan, any comments from you as well? I'm curious to see what your findings are and challenges were.
So absolutely, you need to make sure you have accurate data and validate your data as you move forward. But as you work with your providers and you partner with them, you can get, your data is never perfect, but it can get to be actionable, and so that it actually helps them to use that data to redesign their care. But what's really difficult is engaging them over that data, because we can create wonderful reports from the health plan or out of their electronic medical record. You can create great tools and alerts and reminders in the electronic medical record. But if providers and teams aren't engaged around this and really convinced that use of this data or use of these tools in the electronic medical record is going to make a difference in patients' lives, is really going to improve the quality of care that's being provided to patients, then it's hard to engage them around the importance of this data. And we use a lot of pay for performance from the health plan or within Geisinger on our compensation system, but it's not just about pay for performance. I need a tremendous amount of money to motivate my partners to work an extra 15 minutes every day on these types of things. But if you can show that by incenting them to try something new, to work smarter rather than harder, to use this data to help them to improve the care that they're providing to patients, then you start to develop that real partnership between the health plan, which can provide such great resources, and the partner. For a long time, health plans and the government or others were sort of working from the outside, and we were sort of trying to push providers in one way or the other, almost with regulation and prior authorization and formularies, and yet to really get movement forward, having this partnership and having your health plan really seen as a partner has been the biggest challenge that we've had. And I know a lot of people look at Geisinger and they say, well, yes, you have your own health plan. Of course, it's easy to see that you'd want to partner with a health plan. But I think that, in this new model of care, in this new value-based world, we're going to need to have a payer partner as a provider organization. It's a little bit like the chicken and the egg, in that there's a tremendous amount of savings that comes from doing this correctly. But unless there is that savings, there's no money to invest in the infrastructure and the data and the resources to get this done. And yet, unless there's that infrastructure, then there's no savings. So you really do need to have a partnership with a payer and a provider together, not all within, doesn't have to be within an integrated health system, but in a shared way to engage the primary care physicians around improved quality. And I think that's been the biggest challenge that we've seen, is getting that engagement and seeing the payer and the data that we're providing is something that is very valuable at improving patient care.
Thank you very much for that. And finally, from our Cigna healthcare plan, John Ponente, what are your comments there?
So I would probably sum it up and say ditto, because I think my colleagues here have hit the big things, is data and then adoption of those using the data to use it in a meaningful way. So yes, we all have challenges with the data and have done things, abstracting data that comes in via fax, or trying to present the provider's data that we get from the health plan. So I agree with Dr. Bloom in that partnership, and again, we're in the same situation, that our medical group and our health plan are the same. And we've worked some things to kind of show the providers at the time of care what data we might have from the health plan that's not in the EHR, to allow them to make decisions on that. I think the harder piece, as Dr. Bloom discussed, is really is having them use the data in a way that's meaningful for the patients. And what we try to do, not only in our compensation of the providers, but is in that adoption, is listen to what they're telling us, but also to give them information back. So in the reports that we can run on their quality specifically, how they compare to their colleagues in the same center or the same part of the Phoenix metropolitan area, those type things. But as a physician myself, one of the things that really tends to work is letting them understand it from the patient side, is really talking to them about how these actions that they're taking really benefit the patient. And I think in all the different processes that we do, even in implementing the EHR and going through meaningful use and you know, the different processes on discharging and you know, make sure you put a follow-up order in the computer, not just tell the patient that they need to follow up. I think when they understand how that has relevance to that individual patient, they're more likely to follow and do those type things. You know, moving forward, you know, allowing them the input maybe into how these different processes work is helpful in that partnership as well.
Okay, great. Thank you, ladies and gentlemen. This has been one very insightful conversation. We do have several other questions of which we will get to you post the event. We do appreciate your time. On behalf, again, everyone, we'd just like to thank Cigna Healthcare from Arizona, Excelsius Health Plan, and Genscher's Health Plan representatives there. We do appreciate the conversation and the insightful experiences you have shared with us today. Thank you very much.
Thanks for having us.
Thanks.
So, ladies and gentlemen, what we're going to do at this point in time is just take a very 5-minute break. We are going to be transitioning to our next presenters. We do want to give our panelists just a few moments to exit the stage, and then we'll continue on. Okay, welcome back, everyone. All right, again, that was a very insightful panel discussion that we did have earlier. We're going to go ahead and proceed forward now and move into our next topic of discussion. To kick things off for us there, we will have representatives from the Capital Advantage Insurance Company. I'd like to bring to the podium at this point in time Dr. Chambers, who will go ahead and introduce the upcoming speakers for the next session. Dr. Chambers?
Hello. I'd once again like to thank CMS for inviting us here today to speak about developing innovative approaches to member outreach and education. As mentioned earlier, Capital Blue Cross is located in central Pennsylvania, serving approximately 1 million members in our 21-county service area. Our broad provider network consists of greater than 11,000 professional providers and 37 hospitals. When we spoke earlier about creating a culture of quality, we spoke of our triple aim framework around improving member experience, quality outcomes that drive improvements in population health, and achieving better value for every dollar spent by the health plan and by the member. Member outreach and education is part and parcel to achieving the pillars of the triple aim. Here to share our strategies at Capital Blue Cross around successful member outreach and education is David Skirpon, our Vice President of Retail Strategy. David?
Good morning, everyone. Capital Blue, our retail component of Capital Blue Cross, really was a vision of many people in our company, and our goal was to transform retail by creating a fully integrated wraparound experience for members and the general public through personalized service, health and wellness education, all complemented by a standing corporate commitment to quality. In December 2012, Capital Blue opened in the Lehigh Valley in a walking mall in the promenade shops of the Saucon Valley. We launched this with one main goal, to establish a new approach of service for our customers and recognizing the customer's role in their care. When we designed the store, we took a lot of time recognizing how the customer thinks and what the customer wants. So if you were to enter our store, which is over 6,000 square feet, you would see it's surrounded by glass windows, and internally all of our offices are glass. And the reason for that was we were trying to create a very transparent environment for our customers so that they understood that our goal was to help them become healthier and understand what they were looking to understand. We offer face-to-face membership and enrollment services. We are open 6 days a week, Monday through Saturday, from 10 a.m. till 7 p.m. But although we're open those hours, we also open early for appointments and stay late for appointments. So it isn't unusual for our team to be there anywhere from 8:30 in the morning until 8:30 at night. We're there when the customer needs us. We offer health and wellness education and training. Part of our staffing includes 2 care guides who are registered nurses who are there to support our customers in their health needs by doing biometric screenings, health risk assessments, helping them with their chronic illnesses, counseling them, and also bringing in experts when needed, such as dietitians and fitness instructors. We also have fitness and training and activities within our store. Part of our store, we have regularly scheduled classes such as Tai Chi, yoga, kids yoga, Zumba, and the idea being that the community can come and enjoy that exercise in our store. We also have nutritional and assessment and training. We help our customers understand their dietary needs. We help them understand if they do have a chronic illness, the best diet they should be following. And as I said, our care guides can support that, but we also use our dietitians from our team to come in and help also. As I mentioned, our store is more than 6,000 square feet in size, and it provides a zone for delivering a high-quality service to our customers. If you were to come into our store, I'm going to give you a little tour to sort of give you an idea of what we look like. As you enter, we have a greeter station that really functions in many ways. You would always be welcomed by an individual. Our hope is that it's always a very warm welcome and that you feel comfortable. If you think of some of the types of stores you may not be comfortable dealing with because of your knowledge, and I'll be the first to admit, I always get a little nervous going into Radio Shack because I'm technically challenged, so I don't always know exactly what I'm asking for. We've created a store that can be intimidating to people because when I tell family and friends that we've opened a retail store for health insurance, they look at me like I'm crazy. So what does that mean? So what we want to make sure is when somebody does enter the store that they feel welcome and they don't feel uncomfortable asking questions. And giving a tour has become a very popular pastime for our employees. But as you walk in the greeters area, you could be greeted by any of our three types of employees. We have service advocates, we have care guides, and we have sales associates. And in that community greeting area, when they give the tour, one of the first areas they will share with you is we have a community service area. And the way the community service area is set up is it can act as a lounge when we're not having an actual meeting or lecture, or when we do need to use it, it can seat up to 40 people. We have a touch screen TV, and our customers can either enjoy a lecture. We've had lectures such as the author that wrote Chocolate is Medicine. He came in and did a great lecture. This was one of our first successes early when we had opened. We had 54 people say they were coming. The space holds 40, and 104 people showed up the night of the lecture. So there was real interest for people to learn, and the space is very designed for that purpose. We also have individualized consultation rooms, which other people may call an office. Our offices are not assigned to any of our 11 employees. It's a universal office, and the idea is it's there for the customer. So if I'm a customer, whether I'm there for sales, service, or care, I may begin at the greeter's desk. I may transition to an area that doesn't require total privacy, such as the one of the round sitting areas, or I may want to sit in an office where I have privacy and I can talk freely, whether it be about my health or whether it be about my health plan needs. One of the most popular areas in our store, too, is our Kids Zone. And our Kids Zone was designed to be very interactive and fun, but also educational. And we partnered with an organization called the OrganWise Guys, and they have a variety of programs available to help children understand more about their internal organs. But it's fun, it's a doll, and it's very engaging. In addition, we have a Wii Fit station, and we have a number of iPads that are chained to the table so that they don't walk out. But they're we've downloaded some educational and engaging, fun games for the kids. And I have to say, it's really makes us feel good when we see parents trying to leave the office and go back home, and the kids are begging to stay because they're having so much fun. We also have a biometric screening and health assessment area where it's a regular station. We have some privacy where customers can get a health risk assessment. They can get a biometric screening. They can sit and talk with the care guide to learn more about their health, either there or many of them would prefer to go into an office and talk more freely. As I mentioned earlier, we have a fitness area where we have weights, we have yoga mats, we have a stationary bike, and we have a treadmill. And although the area gym equipment is not meant to be a gym or a substitute for a gym, our hope is, and the way it's been working is, our customers come in, maybe they've never done practiced on a treadmill before and they feel uncomfortable going to a gym, so we can help explain to them how to use it. What's really been a big surprise for us is how many local fitness experts have come to us and asked to teach classes such as Tai Chi, yoga, Pilates, Zumba, boot camp. And although the space isn't really large, it's designed for about 10 to 12 participants. Our classes have pretty much remained booked consistently, so that has been a very popular area. Another part of our store that's unique, and again, when I'm describing this store to family and friends, they're a little surprised when I mention we have a healthy cafe. We partnered with Rodale Incorporated, and Rodale is a publishing company. They publish Prevention Magazine, they publish Men's Health, but they also have an organic food division and catering business. And we've partnered with them to create a healthy cafe that serves smoothies, salads, sandwiches. Real popular now are whole fruit pops that children really enjoy. And we've created an environment that I call a healthy Starbucks. We have Wi-Fi, free Wi-Fi, and a number of chairs where people can sit and talk and learn more about the classes that we have and the different programs we're offering. And it's really become a popular addition. Another community-based initiative is we have a community art wall where we have reached out to local artists, and every month a new artist displays their art, and we begin with an artist reception, and it's become very popular. And again, it's brought people into the store. Capital Blue's team of professionals include, as I mentioned earlier, service advocates. A service advocate is really an extension of a call center. A service advocate can answer our customers' questions. It can help them understand their benefits. It can explain the process of a claim. You name it, they pretty much are able to do it. We also have sales associates who sell individual insurance as well as Medicare. And we have care guides who are registered nurses. Both our service advocates and our sales associates obviously are licensed. And again, the idea is to provide 6-day-a-week one-on-one service at no cost to our Capital Blue members. In addition to one-on-one service, consumers can take advantage of various community events planned throughout the year. Capital Blue Lehigh represents the first step in creating access, consumer-centric facilities designed to support a complex array of individual health needs for a diverse member base, including member engagement, outreach education, and in-person wellness solutions. When we think of our targeted outcomes, we really wanted to enhance the customer experience to best align with a seamless, positive experience for our customers rather than a transactional operational experience. Our goal really was to minimize or eliminate confusion for our customers or unneeded wait times with ongoing engagement using technology and human interaction. With healthcare reform on the horizon, this has been a great opportunity for us to hold workshops in our community room and help educate not only consumers but group administrators and small business people as to what the changes are and how they're going to impact their employees. We're also immediately available and responsive to our customers throughout the life cycle, not just when they have a problem and just when their needs are the greatest. We've also really worked hard to improve team communication between our employees on our team, because with the universal offices and with the fact that we have employees that touch sales, service, and care, it's very important that a customer can come in at any time and not have to retell their story and feel as if the person that originally helped them shared that information and is continuing to help them through another person. One of the things we strive for is that the customer will never walk away angry. They may not always receive the answer they want, but they will always receive an answer. We feel at the store that the buck stops with our team, and we do whatever is necessary to get them an answer in a timely manner. We also try to maximize every opportunity. Every time we touch a customer, we want to make sure that they understand everything that's available through the store. So in other words, if somebody does come in for a sale, we want to make sure that they go over to a care guide and have a health risk assessment the same day, or if they can't do it that day, that they're scheduled for one so that we can begin their journey of understanding their health better. Or if somebody comes in asking questions to a service person and they may not have the right plan for their health insurance that they can then talk to a salesperson. It's very important we try to give every new customer a tour of the facility so that they understand and have the ability to use the store the way we'd like them to be able to use it. We really look to educate, support, and reinforce what we have so our customers understand it. The consumer experience. A lot has been said over the past few years, especially with health insurance, on what do consumers want, what makes for a unique and special consumer experience. We believe it's really important that we provide a warm and welcoming environment, and that we're focused on meeting customers' needs and educating customers on the tools and resources and support available as a member. We want to make sure that we're not just introducing all these great tools, but not helping them understand how to use them and make them provide or allow them to receive greater value for their health insurance than what they do if they don't understand the tools. We continually focus on making the customer feel comfortable and make them feel that we appreciate them being there, because we feel them coming to our center gives us an opportunity to educate and support their needs. We really focus on that the customers do not feel as if it's a dead end, that they've come here, they've already been upset because they didn't get an answer somewhere else, and that then they come to us and they're not going to get an answer from us. So the whole idea of providing the customer with an answer at every engagement is very important. We also want to be accessible and transparent. Again, we don't want the customer to feel that we're there to do anything other than to help them. And we always try to deliver on our promises. Follow-up is key, because if we do not do what we say we're going to do, they lose confidence in us. As I mentioned, although we are open retail hours, Monday through Saturday, 10 a.m. to 7 p.m., we want our customers to know that we're also available by appointment, and we make ourselves available to them so that they can, so that we can be there when they need us. And we also try to focus on the fact that customers do come first. If we didn't have customers, we wouldn't be here. So we recognize that if we're not delivering the level of service that the customer needs, they can go somewhere else. And we work very hard to make sure they feel good about this. And as we are in such a changing environment of a changing industry, the continuous communication and accessibility to us is becoming more obvious every day. Our Capital Blue team members conduct formal and informal sessions. It is a very relaxed and reactionary environment. In other words, some people feel very comfortable just sitting around a chair and a table talking. Others want an office. Some customers really feel comfortable talking over a cup of coffee in the cafe. We try to be able to fit the needs that the customer is looking for while also answering their needs. We also have really, almost to my amazement of the team of people in our store, have developed an events program that is just unbelievable. We had an event just this past Saturday. It was called Fun, Fit, and Sun. And the idea was it was going to be a summer health fair where we did screenings for skin cancer. We had biometric screenings. We had fun things for the kids, face painting. We had our Rodale Cafe partner did an outside healthy barbecue to help people learn how they could have delicious food, but it could still be healthy. We had our event from 11 till 2. We had hoped to have about 400 people there during that period, and we had 681 people come in on Saturday from 11 to 2. So the desire to learn and see what is there is obvious. We have had events ranging from authors launching their book to unique health topics to art, and it just really has been very well received. our community is hungry for more information. They don't just come for the free food and the possible giveaway. They appear to be very interested in learning more about how they can live a healthier life. And with our Rodale Cafe, one of the nice things about it is if someone is a diabetic or they're on a gluten-free diet, they help them by sharing exactly the right foods that they can eat and enjoy and stay healthy. So our retail experience in Capital Blue has been very successful, and we're looking forward to opening our second store early in 2014. Thank you.
Good morning, everyone. My name is George Park, and I wanted to follow up on Dave's background on retail stores and talk about some of the other innovative approaches that we've employed. And when we talk about innovative approaches, one of the things that Capital had looked at is taking advantage of some of our prior successes through some of our consumer advisory council panels that we had established in the early 2000s. Taking off of that, in 2009, Capital looked at expanding the consumer advisory councils across our entire lines of business. So with that in mind, and in complement to that, we looked at our Medicare lines of business. And as such, we ended up creating a Medicare Consumer Advisory Council. I think what really makes this group unique is the fact that not only is it representative of our community with 8 members of the community represented, but it also includes both our executive and our general management teams. So it's really getting our senior team involved and really interacting with our community and with our member base. The Consumer Advisory Council meets in the spring and the fall, and it really covers what we would consider to be a broad spectrum of topics designed to address member health, wellness, and coverage needs. Some of those include the health plan's role in supporting member needs. When we talk about that, we're looking at things that would include fitness and access to fitness centers, pharmacy needs, general health, and just also supplemental product offerings that we would be able to offer as the health plan. Additionally, we look at the provider's role in supporting members' needs. Again, this gets back to the idea of how the member and the provider interact and engage in the member's overall care. So this is looking at areas that would include access and quality of care, focused engagement with the providers, and also discussion as far as networks and network access options. We also talk about benefit design changes. As we go through our year-over-year changes, we want to work with our beneficiaries, with our members, to really discuss what some of their needs are, what some of their expectations are, and what some of their overall wants are in the benefits that we're providing. We also look at healthcare enhancements. When we talk about healthcare enhancements, we're really looking at the overall discussion of the member and their role in concert with their provider and with their healthcare plan. We also discuss customer service opportunities and options and just general service initiatives. So this is looking at the overall level of care that they were provided, also as far as readiness to answer the questions, ability to answer the questions, and just their overall success or their overall satisfaction with our customer service. Where we're looking as far as next steps with our Consumer Advisory Council is we're looking at the fact that we've seen some incredible successes in the program, both from the commercial lines of business and also with our Medicare specific teams. So what we've been looking at is how we can expand on that and how we can reach a broader demographic. So some of what we're looking at are webinar presentations, with the idea that we're able to, with the advent of new technologies and with a changing demographic of our membership, being able to really reach a broader spectrum of our members and use some of the current technologies that exist to provide that outreach. We've also looked at doing surveys and sending surveys out to the members with the idea of we want to make sure that we get information from them, again with the idea of meeting to the beneficiary or member needs. Also looking at the retail center presentations. As Dave alluded, we have our new retail center, which provides a phenomenal opportunity for members at all ages to engage with our service teams and really get to understand what our products are and what we represent. What we want to do is look at utilizing or using the retail center as another vehicle for us to be able to provide these member outreaches, member engagements, and really just introduce the member to the overall services that we can provide to them. As we look forward and we start looking at the future, we're also looking at other considerations as far as using expanded use of social media tools as a way of reaching to our members. Also looking at the idea of expanding retail opportunities in other markets, and then also looking at the ability or the idea of expanding our existing Consumer Advisory Council to include a larger group of members from the general population, also looking at doing segmented or directed consumer advisory councils, realizing that we do operate in 2 different areas in central Pennsylvania. So with that, we're really seeing this as, again, yet another innovative way that we can try to reach our members and really engage, not just at the ground level, but also being able to engage at all levels of our organization. So with that, I'm going to turn it back to Dr. Chambers to address any questions you may have. Dr. Chambers? Thank you.
Thank you, George. So in conclusion, our mantra of meeting the member where they are has been illustrated through some of our innovative strategies around member outreach and education, and we're finding a lot of success in these. We're getting a lot of positive feedback and comments from our Senior Blue members around what we've been doing for them to meet them where they are. So with that, I will conclude our talk, and thank you so much.
Thank you, ladies and gentlemen. We do appreciate that. Well, everyone, what we're going to do at this point in time, for the sake of schedule, we are going to go ahead and actually break for our 1-hour lunch period. We will reconvene at 1:15 Eastern Daylight Savings Time, and we will continue with our furtherance of, we have additional panel discussions available, as well as several other presentations to share with you. So we look forward to you joining us at 1:15 this afternoon. Thank you.